This is Roger Green, host of the Surfing the Mesh Tsunami podcast. Today, we're offering 5 conversations from episode 24, our discussion about looking back at EASL from 6 weeks after, plus a 5th discussion, which is a review of the question of the week from conversation 23. We've got Jeff McIntyre and PharmaNest CEO and founder Mathieu Petitjean for the interviews, and Mike Patel and Jose Willems for the discussion of the QOW. Here, the question to Mathieu Petitjean is, what are the implications of these takeaways, as he described in conversation 1, for your business? Matt starts the answer with a question. Will biopsy-based analysis become part of the surrogate endpoint? As he points out, they're not today. And creating the necessary data to make this happen will require significant effort and expenditure. If not, large biopsy-based analyses are unlikely to remain relevant to the large phase 3 trials. Regardless of the answer to this question, Matt believes digital pathology will still be important in preclinical and early stage work and in other efforts to define underlying liver structures and false beta, other classes of disease, for example. Also, he notes digital pathology is extremely valuable in an array of other liver diseases and in non-hepatologic markets, notably including oncology. One way or another, he is confident that PharmaNest can be honest with clients, assess the situation realistically, and continue to make contributions to hepatology while growing as a business. As we've discussed over the last several episodes, EASL Congress 2024 was really a seminal, empowering event for the MASH and MASLD community. Listening to these 2 dialogues with Matt Petitjean and Jeff McIntyre gives you a sense of the many different ways that players could look at this and the impact that it will have on their businesses or their not-for-profits going forward. It's an important set of issues and I think really intriguing. So just sit back, listen, learn, absorb, and when you're done, join the conversation in our LinkedIn discussion group. Really interesting. And then the question becomes, so without giving away competitive secrets that you might not want to, how does it change what you do or how you think about going forward? Because really, the value in going to these meetings isn't merely to learn, but it's to figure out how to make better contributions to science and better contributions to commerce, really, at the same time.
Mathieu Petitjean.
There are maybe 3 answers. The first is we like to remain very, very collaborative with our clients, with the sponsors, because the question that we put on the table today, the sponsors put them on the table today, and our position, which I have reinforced in the team, is be very open, very true about what we can do, what we can't do. Because we don't want to mislead sponsors and their biomarker teams to say we have the solution for everything. No, we don't. We can definitely help. We have a roadmap to become a surrogate endpoint, but we are not there yet. So the first thing is we need to share and have a very trustable discussion with sponsors. This situation, it is what it is. And we have these discussions based on our data. And we are not feared. If biopsies go away, great. If my business needs to get reorganized, okay, I know how to do this. So we don't want to slow down the transition away from biopsies if biopsies don't bring significant value to these studies. Okay, so first of all, we'll find a way to get reorganized. And now let me tell you about ways where we can reorganize and where we are focusing. First, our biomarkers work as well in the context of preclinical studies. In the context of preclinical studies, there is a lot of activity trying to understand what are the impacts of the different classes of drugs on the phenotype of fibrosis. How do these drugs work? So that's number one. The second thing is, what are the hypotheses when you combine them? Are there ways to combine compounds so that the effect is magnified in a significant way? And the third arm is that we do more than fibrosis. We do all kinds of inflammatory and tissue injury phenotypes, which can apply to the study of antifibrotic compounds, but not only. So preclinical remains an area where we bring a lot of value. The fact that our biomarkers are also used in the clinic creates a translational avenue that is valuable. The other way to look is that fibrosis is not a liver-specific condition. There is fibrosis in other organs, and we are very active in Crohn's disease, where Crohn's disease is a fibrotic tissue because the strictures are basically very visible phenotypes of fibrosis. You could look at a stricture in a Crohn's disease patient in the same way you look at highly fibrotic livers. And what happens is that the different inflammatory flares that happen during the life of a Crohn's patient create an underlying development of fibrosis. So there's fibrosis build up to the point it's visible and creates pain, discomfort, and all these symptoms. So there is a lot to translate from what we've learned in the context of liver to IBD and Crohn's disease. And this is an area that is fascinating, where we can bring a lot of value, and where biopsies are part of the standard of care. You do them during endoscopy. So we don't have this problem of risky biopsy. So that's an avenue of a lot of interest. And there is a third avenue besides exotic fibrotic conditions where we can bring value, which is specifically in the area of oncology. You probably know that tumors are encapsulated by fibrosis. That's the good news. It's a way to protect the tumor to spread. But at the same time, that capsule is a barrier to all kind of anti-PD-L1 treatments. So you can't. And then the modulation of that capsule through combinations involving antifibrotic compounds, it's a way to really enhance the efficacy of therapies in oncology. So this is very new, but it's an area where we bring value. So to sum up, what we took away from EASL is, number one, we need to be very honest with our clients and sponsors and not be afraid of biopsies moving away. That would be a great. And that is not going to take us out of business. We have other plans that will maintain us in business to possibly help should we go through a generation of studies where biopsy tissue will be needed, not only for histological assessment, but also for complete phenotyping of patients.
That's interesting. Phenotyping really does take things to a different level. If you hang out with me long enough, you'll probably know, if you don't already, I say the same things over and over again. But you mentioned breast cancer. You know, in 69, when Nixon was president and declared that we were going to beat cancer, he thought there was one such thing as cancer and that he was going to find the magic bullet. At first, we had to learn that tumors of different organs were different. Then we had to learn that breast, for example, had multiple kinds of tumors. And then you could kind of work back towards this quasi-integrated theory towards something like a PD-1 could treat in a whole bunch of different situations. It's intriguing to think that we can take the slides that exist in the biopsies that have been done in the past and use them not only to approve drugs, but also to phenotype patients. That we can start to understand, because I believe from the first time I walked into this disease, and late Stephen Harrison showed me a map of all the different ways that you could affect a liver in terms of fatty liver, that there were so many different paths to action that it couldn't be that this was just one disease.
Yes.
Right?
Absolutely.
So therefore, logically, we learned this with HCV also, but logically, phenotyping had to be a key to solution. And the idea that you can make more efficient use of tissue that we already have to phenotype it, if you know how to do that, is really, I think, interesting and important.
Yes, we do. And we've demonstrated, and we got manuscripts on that the histological phenotype of fibrosis really depends on its etiology. So if you have NASH fibrosis, or you have hepatitis C fibrosis, or PSC as well, or even fibrosis driven by alpha-1 antitrypsin deficiency, the phenotype of fibrosis is different. So you might have other etiologies of injury, of liver injury, that modify the histological phenotype of fibrosis. And now we are working on a side-by-side or an overlay of what we obtain from an H&E, which is basically a tissue panel, a single nuclei, single cell tissue panel, and overlay that with the fibrosis phenotype to look at the same time at the injury phenotype and at the fibrosis phenotype. In other words, we can make the difference between a hot septal breach and a cold septal breach. So I think through this approach, we will be also able to identify patients that can live with some level of fibrosis in the liver and patients that need to be addressed as well. So develop a prognostic of severity to be able to say, well, you're both in F2, but you know, this F2 here is the one that we need to address. There is some sense of urgency, whereas this other F2 probably needs to be addressed in a totally different way. So again, it's stressed the fact that fibrosis alone is not sufficient to manage the way you handle a patient.
So one more question. It strikes me that one of the reasons that alcohol and non-alcoholic steatosis were viewed differently is that there are differences in the injury and phenotyping patterns between the two.
Yes, absolutely. Yes, it did.
Has anyone taken a look at Med-ALD this way?
Oh, yes, we've done a study. It's a proof of concept study with collaborators in Japan where they had a cohort with purely metabolic MASH and purely alcoholic MASH. And we clearly demonstrated that the phenotype is different. And the test has an OROC of 0.95. So it's significantly different. The challenge is that now we have to validate this biomarker. And in order to validate, we need a large cohort where we know exactly if you have a patient that is drinking or not drinking. And I think the field is at this point to say, okay, what are the non-invasive tests that we need to use to really stratify patients?
Level of alcohol, yeah. Got it.
Yes. And I think the Madrigal study has this kind of biomarkers, and we are all looking at really understanding alcohol consumption.
And now back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingmash.com. Also, remember to answer our questions of the week so that you can have a chance to hear panelists discuss them and be part of that discussion and recognized on the program. In our next episode, Rue Ranella joins Jorn, Louise, and me to discuss the recent expert recommendations on resmetirom paper published in CGH. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.